It's a real privilege to be here, and also I'm humbled by all of you that you were able to make it here and give us your time. I want to focus a little bit on chimeric antigen receptor T cells, which are the CAR T cells many of you have heard of. And for the past couple of years, we've been talking a lot about them, and I'm very pleased to say that over the past year, we've been able to grow the program because of you and your support to have at least 5 CAR T cell trials ongoing, but actually a few more even about to open. So this makes access a better issue for all of us. For all of you who know me, and I actually have seen a fair bit of you either in the clinic or an inpatient or somewhere, and really it's been a pleasure to do that. You know that I'm not only so much about immunotherapy, but I'm also a quality of life girl, right? I love quality of life, and I want everybody to have a good quality of life. And something that's become so apparent to me over the past couple of years is that there are some patients for whom CAR T cells give this quality of life. This is something that we've never seen before. We've had people go for a year, 2 years, without ever having to come back to us to get a prescription for anything related to myeloma. And if you can imagine that freedom from no Revlimid, no dexamethasone, no daratumumab, no lab draws, going on a trip for 4 weeks and not talking to us, no MyChart messages, none of that. To me, that's the best thing ever. Not that I don't want to see you, I'd like to see you like at the mall or something like that, right? I don't want to see you necessarily in the clinic. And what this did was open our eyes, I think, to the possibility that something like a cellular therapy could really give you back your life. That thing that every day we're just asking, is it okay? You know, are you having the same quality of life? Can you feel your fingers? Can you walk without thinking you may fall? Those things, and part of that is less visits to UCSF, right? I mean, not that we don't want to see you again, but you probably don't want to come as often. One of the things that we've been focusing on is making this T cell better, right? Because there are people that are out there that are living 1 year, 2 years, that have gone back to work, and I hope you hear these stories tonight, that have been able to give back to the world because of what therapy has done for them. But there are also people that have had the promise of this, and then that didn't pan out. And then there are people that wanted to get this, but it didn't work out for a couple of reasons. One is access. There was no clinical trial spot. They didn't meet the criteria. In some way, the disease wasn't this or that, and there just wasn't enough to go around. Or two, they didn't qualify because of some physiologic reason. Renal failure, low counts, something just wasn't right. They couldn't make it happen. And these are the 2 areas that we want to make better. We want to be able, like Tom said, to take back the CAR, to figure out how to make it work better so that it lasts longer, but also figure out how to make it work better for you, meaning that you have more access to it. 1, 2, that maybe you didn't qualify before. Maybe there's a way that we can change what happens during the CAR so that somebody who's on dialysis could get it. Somebody with renal failure could get it. Somebody who may not be able to come for this many visits could get it. Somebody who wants to do it as an outpatient could get it. All of these things are factors that are part of our program and that we want to bring both immunotherapy and quality of life to all of you. And I really hope that you guys can take away from this evening that it's a 360 focused mission, not just for immunotherapy or cellular therapy or targeted therapy, but all of these things, but also for patient therapy, which is all of you combined and all parts of you and your caregiver and your families. So with that, I'd like to bring up Jeff to talk about a remarkable story, I think, that I'm excited to be part of.
I'm going to interview you first.
Oh, okay. Well.
How does one make a CAR?
Okay.
What is a CAR?
Right. So for those of you who have not heard this before, the CAR T cell is a great way to combine the specificity of an antibody, which something like daratumumab is, and the cytotoxicity, or a T cell, that machinery. So on the one cell, you have an ability to be specific towards a certain protein on the plasma cell, which is the malignant cell. And inside that cell, inside the efficacy cell, the T cell, you have this machinery that kills. And so once that T cell hooks on to the plasma cell, it now gets a signal saying, hey, I want to kill you. And those cells, which is good if you're a plasma cell, not good if it's not, but it is a way to get targeted therapy in, and it's your own cells, right? So we don't have to go and collect somebody else's marrow. We don't have to go and get some unrelated donor. It's your own cell that can be harvested.
So how do you take a killer cell from Darcy Grigsby and turn it into a specific killer instead of just a random killer?
Right, it's a great question. So it used to be that we would think T cells from someone else or myself could kill myeloma, but they're not doing a good job to do that. So we really have to make them specific. The way we do that is to transduce these cells, and that's a fancy way of saying we take a viral particle and make sure that it expresses or displays the same antibody that's specific to those T cells, and we program that cell. We push those viral particles into the T cell and make that T cell a new T cell. And it's sort of like thinking like you have an umbrella that's a cell, but then now you have this little thing sticking out of it because now you've programmed the cell to express this. And now the T cell is able to say, okay, I have a mission. I'm not just going to kill this or that, I'm going to kill specifically that myeloma cell. And that goes through an engineering process, a genetic engineering process that takes approximately 2 weeks, sometimes because of quality control, making sure that there's no infections, et cetera. It can take 4 weeks, but generally 2 to 4 weeks, something like that.
Great. And some of you know, not all of you know, that Alex Marson at UCSF, very wonderful young scientist, has discovered actually how to program the killer cell without using a virus particle, without using a former HIV particle, but to use...
Yeah, there are different ways you can do this. There are things called transposons, which are DNA-based little genetic particles that you can push into the cell and not use a virus. There are other variations of that, and then there are other smaller particles that you can get into the cell and have them take that as a fake DNA sort of template, and they can sort of transcribe the DNA and think that it's their normal DNA, and using that express all the proteins on the surface that you would want in order to specifically target that tumor cell. So there's so many levels of experimentation and research that go into making each one of these T cells, and you can really start from the basics of the DNA of the own cell versus bringing some other DNA versus bringing in a novel DNA sort of particle versus making a new antibody, and Haroon's going to talk about that with nanobodies, versus just how you culture the T cells or how you make them in a big vat that can change how those T cells may sit in any patient's bodies, may react to the tumor, and how long those T cells will last, so that if it ever comes that your myeloma comes back again, maybe those T cells would be ready to go standing guard.
Thanks, Nina. Nina Shah. So I think one of the messages that you got from Nina is that when we talk about CAR T cells, it's a platform. It's not a single molecule like a single drug. It's a platform that can be developed into better and better and better agents to kill myeloma. And so the CAR T that we are now using in our patients, like Darcy, if you could come up here. Actually, maybe we should do the high chairs. Yeah, let's do the high chairs here. So the CAR T,
well, that's okay, as long as they don't.
the CAR T that we got for Darcy is just a first generation with the scientists that we have here.
You can stand if you want to stand.
And the scientists at other institutions. We should be able to improve upon these CAR Ts over the next few years. And so many of us do believe that this is going to be a platform that can cure myeloma down the road, and hopefully other cancers like leukemias, lymphomas, which we're already doing, but solid tumors as well. Anyway, Darcy Grigsby, welcome.
Thank you. Am I?
So I've known Darcy for how long?
I came to see you, I think, very soon after I was. I'm Mike.
You're Mike's too, I'm sorry.
So right. After I was diagnosed with multiple myeloma in 2004.
So this is when I was still in Berkeley. Yeah.
He was at Alta Bates, Jeff,
Yeah.
and I followed him to UCSF. And there was a moment when he said, my peers are retiring. And I thought about it. And then I decided I wanted to give my life to fighting multiple myeloma.
So we've known each other for 15 or so years now. In fact, Darcy works at UC in Berkeley and teaches art history, and I had a wonderful experience taking my eldest daughter to hear Darcy lecture on Impressionism. It was a wonderful afternoon. Darcy, how many therapies do you think you've been through
Oh,
since 2003 or 4?
what do you think? Maybe 10?
Yeah, probably
12?
something like that. I mean, we had to count them to put you on the study, but it was somewhere around 10 or 12. And all of them had side effects.
And all of them entailed coming to UCSF quite a bit. There was a certain one, I can't remember what it was, that had required consecutive days, which is really...
Carfilzomib.
Yeah, which is really difficult when you're... I've been teaching full-time as a professor at Berkeley throughout this process. So sometimes I would be weak enough that I needed a stool or whatever, but I only took medical leave when I had the stem cell transplants in 2006. So yeah, it's been a long haul.
So every time a new drug came along, we would, and Darcy's myeloma would come back. But you got myeloma at the right time, actually.
I feel that it was an incredibly sad moment when I got myeloma when my son was 4 and my daughter was 13, and I didn't think I'd see them grow up. But then I've also felt that I have been so lucky that it happens to be this moment in myeloma research, and that it's this cancer that is so responsive to so many therapies, so that you too can be obnoxious and brag. brag. I'm so lucky to have the cancer that allows them to brag.
Don't you feel great, all of you out there, when we say, you're lucky to have myeloma? So when your myeloma came back again and we were running out of conventional options, we talked about experimental therapies, and many of you have been on experimental therapies. In this case, it was the chimeric antigen receptor T cell, or the CAR T cell. And how long ago did we give you the CAR T?
I had the CAR T. I'm now in my 18th month out in full remission.
Complete remission, MRD negative.
Both of these doctors came into my room and did that, and Nina, and did that ridiculous survey to see if I still had cognitive
every
control.
day.
And what I couldn't believe is the survey that I had to answer, what 3 words were they? Something like milk. Milk what? Milk, sensible, and before. I am going to say 3 words to you. Milk, sensible, and before. Can you say them back? And I did it the first day, working hard, made sure I got it, milk, sensible, before. And then it turned out for the entire 2 weeks, it was the same 3 words. I thought it was gonna try to keep up. I had to keep up with novelty, but instead I just had the whole thing memorized.
We've changed that, haven't we, Nina? We still have to milk sense. So even I could take the test.
I think all of you, hoping you will never get multiple myeloma, but just in case, should now memorize milk, sensible, and before, and they'll keep treating you.
Did you get very sick during the CAR T cell?
No, I really didn't. In fact, Dr. Martin and I were just laughing how I had been told that, I was very nervous going in, but I had been told that typically, in fact, I think you said, in the next few days, you're going to feel terrible. You're going to have fever and whatever. And I had such a mild reaction when Dr. Martin came in at one point. I said, it's not working. Nothing's happening. It's obviously, once again, I've always been someone who's responded to the therapies, not in a dramatically great way, but in a kind of moderate way, which kept me alive for years and years and years. I plateaued for a long time when other people would have really great results and then come down. I managed to stay kind of even, and I was like, of course, I'm going to be the one that doesn't have the fever and doesn't have the results. And it turns out I got the results anyway.
You got the deepest response you've ever had.
Yes, definitely.
And maybe the longest, hopefully forever.
Mm-hmm.
How does this compare to an autologous stem cell transplant?
It was much easier than the autologous stem cell transplants. We did a tandem. Yeah, we did too. Tandem, so that was 2, and I was very, very weak. after those, and I felt fairly good after the 2 weeks in UCSF, and then I had to have 2 weeks in a Airbnb in the area in case I had some cognitive relapses, and I needed to have people who knew me to know whether I always call, the bathroom sink a lampshade. And if they knew I always called it a lampshade, we didn't have to call emergency, but if I didn't, so I had lots of my sister and friends come stay with me. But it was all incredibly easy, actually. Yeah.
So obviously what we're hoping for in Darcy's case is that these cells are immortal and that they keep killing the myeloma. For those of you who are offered research options, think about the possibility that it could actually wind up being as good as a CAR T cell. But
Yeah.
were you on prior studies? I'm trying to remember.
Oh, tons.
What else did I put you on?
I think a lot of the time it was experimental. I was on SAR, wasn't that
Oh,
experimental?
yeah, you're in Tom's antibody study, yeah.
Yeah, and you always wanted me to be on Velcade and Revlimid, even though neither worked for me too well.
I'm sorry.
And I went to Scottsdale. At one point when
Clinic, yeah.
the Mayo Clinic, because they had something in advance of it being available. So yeah, I had a lot. While teaching, I went to Scottsdale. Yeah. No, this has been glorious.
Are there any questions for Darcy? She has been an amazing patient. I love you.
I love you. This man is very, very special. And his decision not to retire has saved my life. Thank you.
Thank you.